Welcome to part 3. This section is going to focus on electrolyte imbalances. I want to start this PowerPoint series by mentioning that every lab is going to have different numbers for what they consider normal for electrolytes. You may see slight changes in the lab value normals depending on where you're working. What I reference in these PowerPoints is what the book considers normal, but our Hinkle and Taylor books don't agree on the normals. So if you're trying to figure out what lab values you should use for like your care plans, look at Lippincott Advisor. Sodium is the chief electrolyte of the extracellular fluid, makes up about 90% of the extracellular fluid cations in our body. Normal serum levels are 135 to 145 milliequivalents per liter. Sodium is very important for control and regulation of the extracellular fluid distribution, as any gain of loss of sodium is accompanied by gain or loss of fluid. Sodium and water do everything together. They are best friends who never leave each other's sides. Because sodium and water are so connected, sodium is going to affect our serum osmolality. Sodium has an important role in muscle contraction and transmission of nerve impulses. Sodium also regulates acid-base balance as part of sodium bicarbonate. Our bodies normally get its sodium through our GI tract from dietary sources like salt-rich processed foods and preservatives. Sodium is eliminated and reabsorbed by the kidneys, and the amount of sodium in our body that it keeps at any time is regulated by our RAS system. If the body needs to transport sodium in and out of the cells, it's transported by the sodium-potassium pumps in the cell membranes. And when I think of sodium, I think of the brain, I think of nerve impulses, and I think of fluid balance. Hyponatremia is low serum sodium levels, less than 135 milliequivalents per liter. Hyponatremia is caused by loss of sodium or gain of water. Loss of sodium can be from GI-related losses like vomiting, GI suctioning, and diarrhea. Excessive sweating like diaphoresis, exercising, and certain disease processes and some medications like diuretics can make the person lose sodium. Hyponatremia can also be caused by excessive water intake. People with inadequate salt intake can also develop hyponatremia. Whatever the cause, sodium loss or water gain, the decrease in sodium causes fluid to move by osmosis from the less concentrated extracellular fluid compartments to the intracellular fluid space. This shift in fluid causes swelling of the cells, resulting in confusion, headache, hypotension, edema, muscle cramps, weakness, tenting of the skin, and dry mucosa. Severe hyponatremia, levels less than 120, is usually manifested by hypotension, increasing intracranial pressure, lethargy, muscle twitching, hyperreflexia, coma, seizures, and even death. The best way to treat hyponatremia is to treat the underlying condition that's causing the loss of sodium or the gain of water. If hyponatremia is caused by loss of sodium, we can replace sodium orally or IV. If the hyponatremia is caused by excessive water, we're going to restrict their water intake. If hyponatremia is caused by a disease, we're going to treat that disease with medications. As nurses, we need to assess our patients' eyes and nose, daily weights, lab values, and monitor their neurological status closely. Depending on how low the sodium level is, the patient may be in the ICU for IV administration of high sodium IV fluids. We want to encourage dietary sodium until the hyponatremia is resolved, and we may need to monitor the effects of any medications we give to treat the hyponatremia. Hypernatremia is high serum sodium levels greater than 145 milliequivalents per liter. Hypernatremia is caused by a surplus of sodium in the extracellular fluid caused by excess water loss or by an overall excess of sodium. If it's caused by sodium gain, it's going to be by ingesting too much sodium-rich foods or salt, concentrated enteral tube feedings, IV fluids that have high levels of sodium chloride or sodium bicarb, or by salt water near drownings, like ocean drownings. Situations causing fluid loss, like fluid deprivation, lack of fluid consumption, diarrhea, vomiting, and excess insensible water loss, like heat stroke, can cause excess sodium levels. In addition to high sodium levels, we may also find serum osmolality greater than 300 milliosmoles per kilo and an increased urine-specific gravity and osmolality. In hypernatremia, the fluids move from the cell because of the increased extracellular osmotic pressure, causing the cells to shrink and without sufficient fluid. The cells of the central nervous system are affected, resulting in restlessness, agitation, weakness, disorientation, delusions, hallucinations, or seizures. Permanent brain damage may occur. Other symptoms may include a fever, edema, thirst, and dry mouth, and even increased blood pressure. Treating hypernatremia depends on the cause. If it's caused by IV fluids, we'll stop administering the IV fluids, and if it's from decreased oral intake, we'll rehydrate the patient. If it's from other causes, we may need to administer special IV fluids or give diuretics. As nurses, we need to assess for abnormal losses of water and low water intake. We also need to assess for over-the-counter sources of sodium and their diet. We also need to monitor the patient for CNS changes really closely. Sometimes we do take these patients to the ICU for close monitoring of their CNS because they can have such severe brain swelling from the excess sodium. Potassium is the major cation in the intracellular fluid. Normal serum potassium levels are 3.5 to 5 milliequivalents per liter. Potassium is the chief regulator of cellular enzyme activity and water content, and it controls intracellular osmolality. Potassium also has a major role in transmission of electrical impulses in the nerves, heart, skeletal, and intestinal and lung tissue. Potassium also aids in regulation of acid-base balance by cellular exchanges with hydrogen. Our bodies get adequate quantities of potassium by eating a well-balanced diet that includes fruits, vegetables, peas, beans, whole grains, milk, and meat. If our diet isn't high in potassium, our potassium diet levels can drop really quickly. The body regulates potassium by aldosterone and is eliminated by our kidneys, stool, sweat, and emesis. The body also has additional regulation of potassium by transcellular shifts between the intracellular fluid and extracellular fluid. And when I think of potassium, I think of the heart. Hypokalemia is a common electrolyte abnormality defined by serum potassium levels less than 3.5 milliequivalents per liter. Hypokalemia is caused by losses from the GI tract like vomiting, gastric suctioning, and diarrhea. Loop diuretics like furosemide and thiazide diuretics cause loss of potassium, as well as poor dietary intake and hyperaldosteronism. In addition to losing sodium with diaphoresis, we also lose potassium. When extracellular potassium levels fall, potassium moves from the cell, causing intracellular potassium deficiency. Sodium and hydrogen ions are then retained by the cells to maintain their isotonic fluids. These electrolyte shifts influence normal cellular functioning, pH of extracellular fluid, functions of most of the body systems, including cardiovascular. Skeletal muscles are usually the first to demonstrate potassium deficiency with muscle weakness and leg cramps. Fatigue, excessive thirst, paresthesias, and lethal cardiac dysrhythmias may also occur. I will say that your heart is very sensitive to changes in potassium. Even levels of 3.4 can cause cardiac issues. The lower the potassium goes, the more severe those cardiac issues become, and they can die from this. Hypokalemia may be mild or severe, and the more severe the potassium loss, the more severe the symptoms and the more aggressive the treatment needs to be. Replacing potassium can be orally or IV. If ordered, we monitor EKGs for cardiac rhythm changes and monitor ABGs for changes, but that's not a Block 1 topic. If our patient takes digoxin, we need to monitor the patient very closely for digoxin toxicity, which occurs when the potassium levels go low. We monitor for signs and symptoms, hoping to find them before they become severe, especially in patients taking diuretics. We also need to make sure a patient has adequately functioning kidneys. Kidneys that are not functioning adequately can retain potassium quickly, causing the potassium levels to rise really quickly, which is equally as dangerous as low potassium levels. We may need to teach our patients about good sources of potassium if their diet cannot sustain normal potassium levels. This brings us to hyperkalemia, which is an elevated serum potassium level greater than 5 milliequivalents per liter. Hyperkalemia is not usually found in people with normally functioning kidneys. We see it a lot in people with kidney failure, as the kidneys cannot excrete potassium when they're failing. We can see hyperkalemia with rapid administration of IV potassium, which is against all protocols. We have to give it slowly. We can also see it with hypoaldosteronism and with traumas and crush injuries when massive amounts of tissues die quickly. As far as medication that can cause hyperkalemia, it's usually related to medications that damage the kidneys like NSAIDs, ACE inhibitors, heparin, and some potent antibiotics. These kidney killers, like I like to call them. Some people may ingest too much salt substitute, like Mrs. Dash, which uses potassium chloride as the salt substitute. We also have diuretics called potassium-sparing diabetics that will make the body excrete excess fluid without any potassium loss. The symptoms we see are major cardiac dysrhythmias, which can be lethal very quickly, muscle weakness, paresthesias, paralysis, abdominal cramping, and diarrhea. Hyperkalemia can become an emergent situation quickly, so managing it really starts with prevention. Watch the potassium levels in people with kidney disease and those taking the kidney killers, and watch levels when we administer potassium supplements orally or IV. If the levels are not very high, we can limit dietary potassium and stop any potassium supplements. We can give diuretics like furosemide to make the kidneys excrete the excess potassium, but the patient must be well hydrated before we do that so we don't create other issues. There's an oral medication we can use called sodium polystyrene sulfate, or Kayexalate, which causes the GI tract to excrete and eliminate potassium quickly because it causes significant diarrhea. In emergency situations, we can administer IV calcium, IV sodium bicarbonate, and IV insulin and IV dextrose, which all cause the body to push the potassium back into the cells. This treatment regimen will be discussed in later blocks, in blocks 3 and block 4. We can also do dialysis, where we artificially clean the blood using a machine that acts as a kidney, which is another block 3 topic. No matter how elevated the potassium is, we must monitor the EKG, the heart rate, and the blood pressure closely. We need to monitor lab values and strict I's and O's, as the kidneys are more likely to be involved with hyperkalemia. And this is the end of part 3.